I want to thank Dr. Lohr for what was actually, I think, just a remarkable demonstration of how translational research is ultimately going to elucidate the biology of early onset colorectal cancer to hopefully allow us to really address some of the underpinnings of the disease to both for better treatment as well as prevention. I now have really the distinct pleasure of introducing Sophia Stadler. She is the clinical director of the Clinical Genetics and Genomics Service at Memorial Sloan Kettering. She is a gastroenterologist as well who specializes in patients with early onset and hereditary colorectal cancer. And on a personal note, she is a very old friend and making me well up with pride because she was the first junior attending that I played a role in mentoring when I was at Memorial Sloan Kettering. And so it gives a teacher just tremendous pride to see when your students have just so surpassed yourselves. So please give her your attention. She's going to be talking about germline genetic variants associated with early onset colon cancer.
Thank you very much for the kind introduction, Noah. And Dr. Weber, thank you very much for the invitation. It's a pleasure to be here again this year. And I have to say, this conference keeps growing from year to year. And Dr. Weber, I think you're there. It's excellent. So what I would like to talk about today is to give you really just an overview of what we are doing at Memorial in terms of germline genetics of our early onset colon cancer patients. These are my disclosures, which are relevant for my spouse who's an ophthalmologist. So what we do at Sloan Kettering for genomic analysis of patients with cancer is we have a very large next-generation sequencing panel called MSK Impact that consists of 468 different genes. And there's a somatic component to that, where we actually test the genomics of the tumor itself. But at the same time, we also use normal DNA, where we take a blood sample from the patient and we match that to the tumor, where we only call tumor-specific mutations on this side. And this is really for targeted treatment that Dr. Eng and others have already discussed today. But the normal can obviously be used for determining inherited predisposition risk. And of the 468 genes, 88 of those genes are on our germline panel, and patients have to consent to both of these protocols if they want their germline analysis. They watch a pre-test educational video. This used to be done by genetic counselors, but because of the sheer volume, we're not able to do that anymore, and it's about an 8-minute long video that they watch. And then we proceed with germline analysis of these 88 genes. The results are given initially by the oncologist, and then the clinical genetics service follows up with all of those patients, and we counsel them and make sure that they're getting the right management recommendations and getting their at-risk family members in for testing. The beauty of this somatic panel is that it also allows us to immediately assess all tumors, pan-cancer, for microsatellite instability. And when we find microsatellite instability, we have a system in place where all of those patients are referred to us for genetic testing, because these are obviously the patients that are at highest risk for having Lynch syndrome. And we previously published data that about 16% of pan-cancer patients with microsatellite instability have Lynch syndrome. 50% of which are not colon and not endometrial cancer. So this is a tremendous tool for us. So these are the 468 genes on the panel, and the ones in blue are the germline genes that we test for. And you see the usual suspect, the Lynch genes, but you also see non-colon cancer associated genes, including BRCA1, BRCA2, and things that you don't see as commonly, MSH3, for example, which was more recently implicated as an autosomal recessive gene in colon cancer and polyposis. So initially, we reported in JAMA the first 1,000 patients who underwent this germline analysis in a pan-cancer modality, and this was really a project by Ken Offit, Mark Robson, and the Department of Molecular Genetics who are shown there. And what we found was that out of the 1,000 patients, 17.5% pan-cancer had a clinically actionable pathogenic mutation conferring genetic susceptibility in their cancer. But what was even more striking is that 30 to 50% of these patients would not have undergone testing using just clinical guidelines for testing, which is what we use today. So many of these patients would have been missed. And this prompted us to really expand this germline analysis program to a much larger effort. And to date, these are our numbers since 2013, when MSK somatic impact rolled out, and then we rolled out the germline part in 2015. We now have over 30,000 tumors sequenced somatically, and over 10,000 tumors sequenced from the germline perspective. So what does this have to do with colon cancer? Well, colon cancer is one of the major cancer types that we have aimed at sequencing. And Dr. Sursek already talked about the Early Onset Colon Cancer Center, and that really helped us to accrue more and more patients for genomic analysis with colon cancer. The colon cancers genes are represented on our panel, and they're split into the high, moderate, low, and the recessive genes, which Heather had already mentioned some of before. So what we have done so far is we assessed 464 patients under the age of 50 with colorectal cancer. You can see that the median age in this young cohort was 42, but the age span ranged from as young as 14, unfortunately, to 49. And about a quarter of the patients were really young in onset, 35 or under, and about 75% were in that 35 to 50 age group, which is a much bigger denominator than the very young patients. The female-male was split pretty evenly, and the tumor location, about 60% were in the colon, and about 36% were in the rectum. About 8% of patients had another malignancy. Notably, about 1.5% of patients had a colon cancer either before or after their diagnosis. Most of these, I have to say, were Lynch patients. So the prevalence of germline mutations in this population of 464 patients under 50 was 17%, and that's similar to Heather's 16%, similar to our pan-cancer analysis of 16%. And Lynch was pretty well represented. Lynch syndrome accounted for about 5% of these cases. Heather's, as you mentioned, was about 8%, which is a little bit higher than our set, probably because even though this was an unselected population, all these patients came to Memorial. And there's a shift over later stage disease at Memorial because those are the patients who are seeking clinical trials, et cetera. And in the late stage patients, there's an underrepresentation of Lynch syndrome because the Lynch syndrome patients tend to do very well and they have earlier stage disease. So that's probably why we have a slightly lower risk of Lynch in this cohort. And you can see that MLH1 and MSH2 were and MSH6 were very well represented among the Lynch cohort. When we look at the distribution of germline mutations according to penetrance, so high penetrance, moderate, what I would call low, and then the recessive alleles, this is what we found. And as it was alluded to, about 30% of these mutations are the Lynch-associated genetic mutations, but we certainly have some of the classic APC mutations, biallelic mut-YH, POLD1, which was more recently implicated as a colon polyposis gene. But I have to say, not all of these are drivers. So what we have the ability to do is go back to the tumor. So for example, we did find 3 patients with BRCA1 or 2 mutations, but it didn't seem that that BRCA mutation was actually driving their colon cancer. It was more of an incidental finding. And so we have to be careful about matching normal and tumor in an effort to decide whether that mutation is really driving the tumor. Because your treatment may not make sense to, for example, give a PARP inhibitor to a colon cancer patient, even though they have a BRCA mutation, if the colon cancer is not driven by their BRCA mutation. So we have the ability to do that, and we're currently doing the analysis to be able to demonstrate this. We also looked at prevalence of mutations by tumor location. So traditionally, we've always thought of rectal cancer as being less genetic. And that's probably swayed by the data on Lynch syndrome, that most of the Lynch syndrome patients have right-sided tumors. But what we found is basically there was no statistical difference between the prevalence of mutations in the colon versus the early onset rectal cancer patients. In fact, Dr. Sursek alluded to this, that in our mismatch repair deficient rectal cancer patients, 85% of them had Lynch syndrome. So that cohort is actually very enriched for Lynch syndrome. And then next, we wanted to look at the really early onset cohort. This demonstrates a small denominator, so this was only about 114 patients. But what we saw here was a little bit surprising. We found that 24% of these patients actually had a mutation, and there was a statistical significant difference between the prevalence of overall mutations in the very early onset, so under 35, versus the 35 to 50 age cohort. So this is interesting, and we're still teasing out whether the tumor data follows this up as well. And this was partially Lynch, but not all Lynch-driven. Interestingly, when you look at the moderate, low, and uncertain genes, the prevalence was the same in the very young versus the 35 to 50-year-old cohort. So what we are doing currently is we are building out what we are calling our Precision Interception and Prevention Center in Germline Cancer Genomics, where we are, as I mentioned, we're doing agnostic testing of all of our cancer cases irrespective of family history. This allows us to do further research on those individuals where we don't find the genetic predisposition, but we're suspicious of one. But it also allows us to do cascade testing of our family members and then to enroll them in prevention and interception programs, including screening through blood tests and other surveillance, other more traditional surveillance measures. In fact, we have rolled out this Part C impact to our young adult population, not just colon cancer. Now you're looking at all patients with early onset or young adult cancer, because other than colon cancer, we know this happens in breast cancer, which you heard a little bit about earlier today, sarcomas, testicular cancer, so the list goes on. And in fact, in this population, we also have quite a high, a 20% prevalence of germline mutations. And then last but not least, this also allows us to do further research on those patients who test negative. So we're doing a trio design study where we are doing genome sequencing on patients with the cancer and mom and dad, pulling out the de novo brand new mutations that are only occurring in the child. So in those extreme cases that were presented earlier, like the 18, 14-year-olds with colon cancer, we're trying to find another genetic event that may have triggered their colon cancer through further sequencing. And last but not least, we also have a new attending, Dr. Latham, who is actually family medicine and genetics trained, who's seeing patients who are unaffected. So these are the at-risk relatives of these family members, and plugging them in is obviously very important for us. So just to summarize, early onset colon cancer has a substantial hereditary component, probably a little bit higher in the under 35 cohort, but the majority of these patients, they're still genetically unexplained, and the risk for colon cancer is not yet known. Identification of these germline mutation carriers offers opportunities for detection, intervention, and prevention, not just for them, but also in their at-risk family members. And events like this are crucial to the success of these efforts. Oh, one more slide. This is our clinical genetics team, and now we actually have seven attendings and 18 genetic counselors, and about 30% of our volume is now on telemedicine. We are increasing that effort to be able to capture individuals in New Jersey and in different parts of the tri-state area. Thank you.